Good afternoon. I'm Jen Shiplin, and you know what? I feel like I don't need to stand up here and say that, but I shall for a refresher. How about that? I am actually going to jump right into our presentation because our speakers have a tight deadline, but I want to very quickly introduce Mary Wells and Emily Pinto, and I'm going to let you ladies speak of yourself.
So I'm Dr. Mary Wells. I'm a clinical psychologist, and I have been working in the area of rehabilitation psychology for 35 years, long time. And I have with me a great pleasure to introduce Dr. Emily Pinto, who is completing her 4th and final year in the residency program in physical medicine and rehabilitation. And so both of us have years of experience, me obviously a lot more than yours, of working with individuals with a wide variety of chronic health conditions. And Cynthia reached out to me, you've been bugging me for a couple of years now, to come and speak to you about dealing with chronic health problems from a psychological and sort of medical knowledge standpoint. I want to start out by saying that neither Dr. Pinto and I are here to offer medical advice. We are here to offer information and perhaps some resources where you can look on your own. But we do want to give you some general information about what it's like to coexist, and all of you know better than we do, coexisting with chronic illness. You want to say a word or two about who you are and where you're headed?
Yeah, so again, I'm Dr. Emily Pinto. I am a 4th year resident at VCU in physical medicine rehabilitation, and I'm really interested in integrative pain management, and so that's where I'll be going into practice next July in Williamsburg, so just down the road. But I'm very interested in really lifestyle medicine and integrative management of chronic conditions as part of my philosophy when it comes to medicine. So I'm very excited to be here today, and we hope that you guys get something from this talk.
So we have not done this together before. I did not know I was going to get to have a sidekick. I've had one all this month, which has been fabulous. So Dr. Pinto and I are going to kind of tag team and just have a discussion up here about how we approach individuals who have been diagnosed with something that's complicated, which is something that we see all day long. And I'm going to let you start about kind of what a medical system has to offer, going through the diagnosis, the treatment, those kinds of things.
Exactly. So you guys have probably been versed in some of this, but when we first encounter a problem in our lives, we might not know what to call it. We know that we have a difficulty with breathing or coughing or something like that, or maybe it's a pain condition. You have something that kind of tickles you that, hey, maybe I need to see somebody for this. And so that's where you go into the medical system, and that's where you can meet residents, physicians, or nurse practitioners, PAs, and they do a full exam to kind of figure out what's going on. You can expect a physical exam, you can expect lab work for depending on what you're coming in with, but you really are looking for, and I stress for this just as a patient, that you really want to find somebody that's going to work with you and advocate for you. I think the patient-doctor relationship is very important, and you should be able to trust that your physician is listening to you. You should feel like your provider cares about what's going on. So make sure that you have a good feeling with your provider going in, because I think that's really important. And you guys have a much larger voice than you might think when it comes to your own healthcare. So don't ever forget that. But you can expect to kind of partner with your healthcare provider, go through a treatment, get knowledge about what's going on with your body, ask for education about what they've seen with whatever particular diagnosis it is. What can you expect? What kind of things have they seen with that sort of condition? Definitely just getting as most education out of it that you can.
You know, one of the challenges, I think, is that our healthcare system, certainly since the pandemic, has been very stressed and very stretched. Mm-hmm. And that is not anyone else's fault. It's just the reality of the circumstances we've been in the last couple of years. As a result of that, a lot of healthcare professionals have decided to take a hard look at what they're doing and whether or not they want to keep doing this. And what that has done is created some access. One of the complaints I hear almost every day is it's taking me a long time to get in. And that is going to be the nature of the beast, I suspect, for another couple of years as things continue to shake out. I think when you're faced with a significant diagnosis, and I'm going to give an example of someone that came in this morning to see us who had a heart ablation earlier this year, recovered reasonably well, but then got diagnosed with cancer and is now dealing with all of those ramifications. And her own, she's older, and her own concerns about what it means in terms of her general sense of well-being. She's used to feeling pretty good, and she's felt pretty good for a long time. Most of us take that for granted. And her expectations about how she was going to feel after having some type of treatment, and who was going to take care of her, and who she should tell, and how much information she should convey with her family, with her friends, with her church network, with all of those people in her life. Those are really complex decisions that each of us is faced with when we're faced with a major medical diagnosis. And I think it's important just to be honest with ourselves about that, and being willing to say, this is hard, this is scary, it's anxiety provoking. And when you're anxious, your symptoms tend to get worse, which is one of those really annoying realities of the human experience. So really allowing yourself to begin that process of, what does this mean to me? And that's where I think the next big thing happens, which is the reality that loss is almost inevitably a part of this equation. Now, for some of us, those losses are temporary. But if you're looking at a chronic illness, almost always there are permanent changes in your ability to function. And I see some of you around the room with oxygen, with walkers, with canes. These are adaptations that we are often required to make. And they're not easy, and they can feel incredibly scary or anxiety provoking or anger provoking. You can get pretty teed off at a lot of different folks around you. Sometimes that comes out towards your physicians, and that's okay, we're used to it. Sometimes it comes out at our family members, and sometimes it comes out towards our faith and our belief in God, and just the unfairness of it all. And that's a reality that a lot of us are faced with. It also means losing the ability to do stuff. We had someone in this morning as well talking about seeing her family go and do activities that she used to be able to do and can no longer participate in. That's a loss. Being able to get down on the floor with her grandchildren has been a real challenge for her. She still does it, but at a great cost to herself. And, how do you begin to find a way to deal with that? Feeling helpless. I used to be able to open the jars. My mother had pretty severe arthritis in her hands, and, ended up with a ton of devices, which sometimes worked and sometimes did not work all that well. And she would frequently end up hollering for me, one of the kids, my husband, somebody, can you open this jar for me? Can you open this letter for me? Can you open this whatever for me? So that feeling of helplessness that comes, I can't do this for myself, and I have always been able to before. I'm going to bring up the issue of driving just because this is a hot button issue with many of the individuals that I've had the pleasure of working with. What I recommend to all of my folks over the age of 65 when they walk in the door, and I think you've seen me do this, where I'll say, if there's somebody in your life that you know and trust, that you can count on, start a conversation every 6 to 12 months about how am I doing? Often that's an adult child. It's sometimes a spouse, although often a spouse is too close to tell. So perhaps a physician or a trusted spiritual advisor or a niece or whoever, but you get to decide who that person is. But every 6 to 12 months, you sit down and say, this is how I think I'm doing. How do you think I'm doing? And then as things change, because as we all know, as we age, things do change. We have kind of a checks and balances, a place to say, you know, last month when I was driving, I noticed that I was a little slow in my reaction times. Would you be willing to come drive around the block with me or drive downtown and back with me to see how I'm doing? Again, that kind of checks and balances. Or for a family member to say, you know, I'm a little worried about you driving. I noticed that you have a ding in the front of your car. Would you be willing to talk about that? So these are hard conversations to have, but if you get in the habit of having them, they're much less difficult. I bless my mother, who was very willing to have these conversations with me because she lived with me. And it really allowed us to move with greater ease through the changes that she experienced during the last 10 or 15 years of her life. With that can come a loss of sense of self or a loss of identity even. Sometimes this is related to having to come out of the workforce. I am frankly highly anxious about the idea of retirement because I don't know who I am when I don't have the Dr. Wells persona to put on. I might be able to figure it out and my husband's ready for me to retire, but I'm like, I don't know about this. So these are really normal thoughts and feelings for all of us to have. And then when something other than our own decision-making interferes with the ability to choose when and how, and chronic illness will do that. It has been known to do that more than once. Do you want to talk a little bit about, you know, how do you begin to counteract some of that? You know, network of support?
Yeah.
Have at it.
So kind of what do you do when you get this? One of the things that we really recommend is lean on that network of support. So finding that person that can really be honest with you about how you're doing and finding those people that you can kind of lean on in your times of need, but also just to be there for you, right? This is your family, your friends, your church members, any other groups that you're involved in, whether they be like a service organization or something along those lines. Those are your people. That's your support network. And I think one of the biggest things that chronic illness is that it can feel isolating. But one of the things that we want you to know is that you're not alone. And not only do you have your support system within your life, but identifying those people is going to be really important. But then also finding groups like this or groups that connect you with other people who are going through similar things that you're going through. It's going to have such a tremendous effect on your mental health when it comes to kind of dealing with this and how do we get through this. You're so much stronger as a team, and you just got to remember who's on your team. Identify your team, and you're going to feel so much better in the long run, I think.
Absolutely.
And then also there's online communities now. So if you can get someone to connect you online with somebody else, or just Google kind of your chronic illness or group, find those connections. That'll make all the difference.
Yeah, I have a patient who had really not stopped being able to walk. She had heart issues, she had she had pulmonary issues, she had all kinds of stuff going on. She was also significantly overweight. And this was creating a real barrier to her being able to get the treatment that she needed. So she decided to take action and change the trajectory of her health, which is really quite remarkable. And I've been really impressed with her journey. But she went online to find all the people who were doing bariatric surgery. So she lost 87 pounds before she had her bariatric surgery. Now she had 200 pounds to lose. She had a long way to go, but she got halfway there before she did surgery because she took shameless advantage of online support groups. And she said that's what kept her going. So those can be real, incredible supportive networks. I want to touch briefly on work. Is anybody in here still working? Are we dealing with? Okay, I won't spend a lot of time on working then. But I think when you've had a chronic illness diagnosis, what does become important is how do you build a life that works for where you are now? And that's not based on a life that was where you were then. You know, and there is often a very significant before and after experience. before I was diagnosed, it was this, or before the injury or before the illness, it was this. Afterwards, it looks often qualitatively different. And so how do you begin to build a life that works in the new reality that you have? This is a really big job. And if you shortcut it, you're not doing yourself any favors. Taking the time to figure it out is hard. It's confusing. It's often emotionally exhausting, but it's worth the journey. Because if you can come to terms with what is, rather than getting stuck in what was or what should be or what ought to be, then you can really begin to figure it out for yourself in a way that makes sense. Acceptance is a big piece of this. I am where I am because that's exactly where I am. Not because I deserve this, not because I brought it on myself, not because I'm being punished, not because someone's had it in for me, just because it is what it is. And I like to bring up, what makes us uniquely human. And Freud said it 100 and some years ago when he said that the most important structures for or the most important concepts for human beings are love and work. And by work, I mean that very broad sense of what gives us meaning in the world. And I think that's a really important thing that often is not talked about in healthcare environments. We get really focused on the importance of managing oxygen levels or blood levels or sugar levels or some kind of data point. But we lose track of what makes life worth living. And that's often where this idea of love and that larger construct of work as meaning becomes so important. So a number of years ago, I created this idea in my head that I called 3 pillars of coping. This is a huge problem. So how do we begin to unpack it in a way that makes sense? So I've broken it down into 3 basic pillars. One is physical, one is emotional, and one is this idea of meaningful activity, or Freud's idea of work. I'm going to let you start on essentials of self-care, since I have an MD in the room, so or DO, excuse me, a physician.
So self-care, it's a really hot topic right now, but it's basically, how do you care for your body? How do you take care of yourself? What new skills do you need with your current mobility status? Do you have any new needs? Do you need a cane? Do you need a walker? Do you need these things to help you be more mobile, to help you have that maximal quality of life when it comes to mobility? Just being real about that. Do you have any new skills or needs with your activities of daily life? Is there something that you used to love doing, but now you're limited by whatever issue you're having physically? Is that something that some doctor or physical therapist or any sort of therapist could help you with, finding an adaptive sort of equipment? That's something that you can explore too. That's where rehab physicians really can be helpful, is helping identify, is there some sort of equipment or strategy to help you with your activities of daily life? Are there exercises that you want to do and need to learn how to do them properly or with your new adaptations? These are all things to consider when it comes to self-care, how you're taking care of yourself physically. Other huge things are sleep and appetite. Just being real, how are you sleeping at night? Do you have difficulties with staying asleep, falling asleep? Those types of things. And talking with your support system about that, including your healthcare team, and appetite as well.
Yeah, and I think often when you have a change in mobility status, figuring out how to nourish a body that doesn't need as many calories is challenging for a lot of us. I know it's been really challenging for me. And figuring out how to deal with an aging body and a metabolism that ain't what it used to be. And how do you begin to accommodate that in your daily routines? Also, for a lot of folks, I see folks who are saying, what about an anti-inflammatory diet? What about a keto diet? What about a Mediterranean diet? What should I be eating? And we've all heard these terms. And beginning to look at, well, what do I like? What am I eating? What makes sense? The research is pretty good that the Mediterranean diet is probably the best long-term strategy. And if you can figure out how to make some of those principles of using less meat, healthier fats, and closer to nature style carbs, so they're complex instead of simple carbs, and staying away from a lot of processed sugar, you're going to do better. And we know that across the board, because those are the foods that support, the body to decrease inflammation. Sugar is going to jack up your inflammation. It just is. So, one of the best things I did 25 years ago, or God, it's been almost 30 years ago. Where did the time go? I quit drinking sodas, because regular sodas are mostly sugar and chemicals. And they were designed as treats. They were not designed as a primary drink. This is the primary drink. Although I'm not sure I like it in bottles. I think this is probably not the best choice, but water is your best bet. And sleep is a huge issue, because your body has a really hard time recovering if you're not sleeping well. So if you're not sleeping well, the place to start is a conversation with your physician team. The problem is that we do not have good medications that replicate natural sleep. We can help you go to sleep, and we're probably better at helping with sleep initiation than anything else. Mm-hmm. There are some medications out there that will help with sleep maintenance, but they take longer. So please, if you are having trouble sleeping, now, if the recommended amount of sleep is somewhere between 7 and 9 hours. Now, the older we get, the more likely we are to wake up at the end of either a 90 or 3-hour window, 180-minute window. Because when we come up, tipping up into the edge of wakefulness, it used to be we would just not actually wake up. But as we get older, we are much more likely to wake up. Now, sometimes that requires a trip to the bathroom. It certainly does for me. But, the goal is to try to limit that to once or no more than twice a night. Again, depending on what your health status is, that can be a really big ask. And so figuring out how to make that work for you, and again, talk to your physicians to see if there are any things that they might be able to help with, but also recognize that the most important thing you can do to manage your sleep is to set a regular bedtime and a regular getting up time, and stick to it. Now, you get to decide when that is. I have to be tied into what my work schedule requires. And most of us in the work world are still, tied into that structure. But human beings by nature, do better sleeping at night than sleeping in daylight hours, because we are primarily visual animals. And so we like the light. And sleep does a whole bunch of really, really, really important restorative things every single night. So we need good sleep every single night. A good night's sleep allows for a much better day. And you've probably all had that experience where if you've had a good night's sleep, you wake up in the morning and you go, oh yeah, I can face today. There are a lot of things that interfere with good sleep. Worry is one of the classics, but there are a lot of other things. Certain foods, certainly caffeine, much beyond 2 o'clock in the afternoon will get you into trouble. I have some personal experience with that one. It's something to just begin to pay attention to. If you're not having trouble sleeping, it's a non-issue. But most of us post age 60 don't sleep as well as we used to. So be really good about putting yourself to bed at night. That's where most people run into difficulties. But also, if you don't have a good night, don't give yourself permission to sleep in more than an hour. Get yourself up and moving, because that if you sleep in until you feel like waking up, then you've screwed up your chance to build up good sleep pressure to sleep the next night. Mm-hmm. And that's where people get into trouble. It's not one night. It's the repetitive night after night after night where you haven't slept well. You try to catch up the next day. You end up staying up later because you're not tired. And then it all starts over again. So these are very, very common patterns. The National Sleep Foundation has really good recommendations on their website, and I highly recommend them. They really have great information on sleep hygiene, which is what we call this. And the sleep docs often tell us, oh, no worries, that the best thing that you can do for yourself is to follow a good sleep hygiene regimen, that it's going to have a much more positive influence on quality of sleep than doing medications. But if you're not sleeping and you need help resetting that ritual, medications can be really helpful. Emotional care, I guess that's my bailiwick. I am a clinical psychologist and I've been doing this for a long time. There was an article on one of the major news stations, I think it was NBC, one night last week, talking about a current research project that said that daily meditation is as effective or more effective than medications for anxiety management. I thought that was really interesting. Giving yourself 20 minutes a day, or even 10 minutes twice a day, to settle yourself down into yourself and find that quiet place within has a profoundly positive impact on your overall mental health. I'm a great believer. I've been practicing these strategies for about 30 years. Again, I learned them kind of within the framework of learning how to treat folks with chronic pain. And I also use a lot of self-hypnosis. I give myself very positive suggestions at night to sleep well. And, you know, my husband hates me because I fall asleep within 10 minutes because I've been practicing these for a really long time. And the best time to practice them is right before you go to sleep, but also one other time during the day. So building in some mentally healthy habits is equally important to building in physically healthy habits. So what can you do to make that happen? Well, I think prayer can be really helpful, but I don't think it's the prayer of beseeching. I think it's the prayer of contemplation. Because if you're asking for something because something's not going well, you're probably worried. But if you're just asking for God's grace, or quoting your favorite Bible phrases to yourself, that also works. You can also just use basic diaphragmatic breathing. Now, if you're here for a Breathmatters program, I'm assuming most of you have lung problems. Is that a fair assessment?
Yes.
Have any of you learned how to do diaphragmatic breathing? Has anybody talked to you about how to use your diaphragm to breathe? Yeah, lots of folks. So it turns out that the diaphragm is a really key player in all kinds of basic underlying functions, including heart function, which I was really not that aware of. So we think about it as regulating the breath, but using your diaphragm also regulates your blood pressure and it regulates your heart rate. And this fancy thing that they call heart rate variability, which is the amount of space between each beat, that actually the more space you have, the more variability there is, the better health you're in, because it allows for better internal balance. And they're also using these kinds of strategies now for things like post-traumatic stress. So it's all tied in together. You know, our human bodies are these amazing systems that we are still trying to figure out. And the more that we figure out how to settle ourselves down, calm ourselves down after we get upset, kind of return to a balance, the better off we are across the board. So again, lots of different strategies. I call it many paths to the top of the mountain, lots and lots. But finding ways of just sort of saying that my mental health is as important as any of my other health behaviors. And then building in something on a daily basis that's going to improve your overall mental well-being. This ties into stress management. I don't know about you guys, but when I get stressed, I stop thinking very clearly. I tend to get very agitated. I start zooming around in circles. I don't make good decisions. So learning ways to settle ourselves down so that we can clear our heads enough to make a good decision about what we're going to do within the next hour can make a real difference. Many folks experience depression as a direct result of their health condition. So for any of you who are dealing with heart issues, it turns out that when the heart isn't functioning all that well, it can trigger more of an endogenous or internal depression as opposed to a situational depression. Do not ever be afraid to talk to your healthcare providers about support if you are feeling depressed. Do you all know the symptoms of depression? Do you know what to look for? Yes, no? Couple of nods. It's a huge problem in our society. They're, depending on which numbers you look at, anywhere from 7 to 25% of any given day of folks are depressed. So it's usually a sense of loss of motivation, of feeling blue or down, of feeling like your insides are kind of moving really slow. There are often changes with appetite, sleep patterns, motivation, energy level, sex drive. Those are what we call vegetative signs. They're really normal changes that happen with depression. Obviously, thoughts of wanting to take your own life or really feeling like life is no longer worth living. You need to talk to somebody. Talk to somebody. This is not your fault. It's not about something you've done wrong. It is not a character flaw. It is an illness. And if you don't take it seriously, it is potentially fatal. Did you have a question? No? Okay. So anxiety is one of the most common symptoms that everybody's experiencing. I think between the pandemic and the current state of the world, everyone is feeling very anxious with the war in Ukraine, the sense of being unsettled in our own country. There's a whole lot going on to make us not feel very settled. A lot of us are anxious for a lot of different reasons, but a lot of us are anxious. I think some number I saw recently was 90% of folks could benefit from some type of mental health services. There are about 95,000 psychologists across the country. That's all there are. There aren't very many of us to go around. There are not enough of us to go around. Even the master's level trained folks, there are not enough of us to go around. Many of us do need and deserve and require assistance. Sometimes it's hard to get there. This is where groups like this, church support networks, close friends and family can really make a big difference. But don't ever be ashamed of having feelings that feel like they're out of control, because that just means that you need some help. That's all it means. It doesn't mean you're a failure as a person, but a lot of us were brought up thinking that. Again, that key of how do you calm yourself down when you're having strong feelings? I think the gift of age is that we really do know that very little is all that important anymore. There are a few things that are, but there are a whole lot that aren't. And there's a whole lot of stuff that we can let go of. I'm really glad I don't have as much life experience to come as you do, but it's helpful to really begin to remind ourselves that, this too shall pass. We'll get there. We're playing our part. We'll play it until it's time not to. So listening to where you are emotionally, giving yourself permission to do some daily self-care on that score. And then if you feel like you need help, being comfortable with asking for some assistance. A great place to start is a primary care physician.
Absolutely.
The third area I wanted to talk about is just meaningful activity. What makes it worth getting up in the morning? For me, the opportunity to interact with the kinds of folks I get to interact with every single day, both my patients, my students, my staff, the folks that, and then my family and friends that matter the most to me, are the reason that I have to get up and get moving every single day. When you're dealing with a chronic health problem, sometimes it's a lot harder to find the reason to get up. That's what I'm talking about when I say meaningful activity. What makes it worth getting up today? What is it that you're looking forward to? I think one of my favorite things that I heard, there was an article that came out in about 2011 on therapeutic lifestyle change, which is a lot of what we're talking about today, things to allow you to feel more comfortable. And their last line is that giving back to others was more effective than Prozac, which is a common antidepressant. I love that. So having something to do, feeling like you can contribute in some way, even if it's a small way, can make a real difference in whether or not the day feels like it was worth living or not. So finding those small things that you can do and connecting and feeling part of something. So coming to this group is probably a great thing that you're already doing. So keep doing those kinds of things that feel like they're worth it. And sometimes the worth it is just connecting with friends. I know for me, just having that phone call at the end of the day when I'm tired with one of my girlfriends, most of whom are also psychologists, it's like, ah, tell me, yes, I know exactly. Oh, great, we're having this conversation. This is wonderful. I can get through the day. The other thing is creating a structure for yourself. You know, most of us use work to create the foundation of your structure. And, you know, when you don't have that, it's hard to figure out how to put that back together. It's what makes me anxious about retiring is how do I create a structure? And, you know, and then giving yourself time to figure out, okay, what's working, what's not working. This goes back to one of those earlier slides that talks about, you know, this takes time to figure out. And also you don't get to do it just once. Usually you have to refigure this about every 6 to 18 months, depending on how your life is going. Does that sound about right? Once a year, every 6 months, you're like, whoa, so I got to figure something else out. Sometimes you have to hook into somebody else's motivation because yours is just not all that strong. That's what I mean by external motivation. I think of it as creating hooks into the future or into the community that pull you out of that funk that all of us can get into sometimes. And this is also where focusing on something other than yourself can be really helpful. So feeling like you're doing something that's not just about you can make a real difference. Structuring your day with a regular wake and sleep cycle, back to good sleep hygiene, having good bedtime and morning routines, which then allow for those good sleep cycles to get set in. They're really helpful. You can set a clock by mine pretty much. I did screw it up last night by about 30 minutes, but I had people over for dinner and I was running late. So, but I'm usually heading upstairs at 9 o'clock because I'm going to be up at 5:30. So, you know, these are things that we learn to do to protect ourselves and take good care of ourselves. So, and your rhythm does not have to be mine by any stretch. I'm definitely an early morning gal. I'm not a night owl. I have other patients who don't get up until 10 in the morning, but they don't go to bed till 2. That's fine. You decide, just stick to it. That's what matters. And then, you know, finding something that feels like it's worth doing, staying connected to the people you care about. And then feeling like you're contributing in some way, you know, whether that's answering a phone during a campaign. I know we just came through a very interesting campaign here in Virginia. I think a lot of my patients at different points in the last few years have found that really helpful to do. Other people get involved in church. I know we got very disconnected with the pandemic. I gather this is your first in-person meeting since the pandemic, and a lot of us are still having that experience. What does it mean to be back in the same room with people we know and care about? But boy, it feels weird. There's some anxiety about that for a lot of folks. But we're gaining a sense of purpose. And then I'm going to just touch really briefly on what's out there in terms of psychological treatment for this kind of stuff. I'm sure you're all familiar with what's available on the medical side, but there are options for psychological care if you feel like you need it. There are evaluations to get a diagnosis, and you know, whether that's a diagnosis for depression or whether that's a diagnosis for cognitive decline. Those are available. We do offer them at VCU in the PM&R neuropsychology office. We are booked out for months like everyone else, but it is there. So if you need something, if nothing else, get on the list. And then with regard to the treatment strategies that I use personally, I use a lot of education like we're doing today. It helps to know what you're dealing with. It helps to know what questions to ask. And often you don't have good places to figure that out. I joke and say I'm a medical translator most of the time, day to day in my work. And then there's cognitive behavior therapy, there's hypnosis, there's mindfulness, there's family therapy. There's a lot of different kinds of therapy options out there. And then I'm going to say, you were going to talk about advanced directives. Do you all know what advanced directives are? Yeah.
Okay. Good. I just wanted to talk a little bit about advanced directives and code status, because those are kind of big things that if you are interacting with the hospital system, especially if you are getting sick, then we really want to protect you and what your wishes and wants are. And this is the way to do it. It's never too early to fill out an advanced directive. It really helps the healthcare team and your family and your loved ones help really honor what you want if this were to happen. This only comes activated if you are unable to make informed decisions about your own care. So it's just like a backup. It's almost like Batman in the corner, he's there just in case, but he's not going to jump in unless you need him, right? And this allows your voice to be heard no matter what. And so I would just really stress that if you don't have an advanced directive, to look into it. You only have to fill out the sections that you want, that you feel are applicable, and the rest you can either cross out or leave blank. So kind of going through the sections of advanced directive, section one is having a healthcare decision maker, your agent. So this is somebody that you really care about, typically either a loved one or a child, that you feel comfortable for them to make decisions about your healthcare if you are unable to. So think about that person, and you can kind of give them all of that, I guess, power in that section one. And section two, this is where you really get to go through your healthcare preferences. If this were to happen, would you want to be intubated? Would you want to be on mechanical ventilation for a long time? Do you want your team to do CPR? These are kind of questions that, if you are able to lay it out, it helps your healthcare team really take better care of you, and for your family to feel more confident in those decisions.
Let me say something here. I think what most of us are not aware of when we're in the middle of a medical crisis is that the healthcare system is designed and mandated to do everything possible to sustain life for as long as they can. Now, when you're 12 or when you're 35, or even when you're 65, that might make perfectly good sense. But when you're 75 or 85, it might not make as much sense. The problem is that the healthcare system can't make those decisions for you. They have to make the decision to sustain life because it's the only decision they are allowed to make, unless you say otherwise. Now, in the moment, if you are conscious and can make that decision, great. Then you say, I don't want you to do this. My mother had a do not resuscitate order after she was diagnosed with aortic stenosis, which is a common heart problem of people in advanced age. She got diagnosed at 86, and she was told that if she didn't have certain types of treatment, that she would have a shortened life expectancy. Well, my mother was 86. What's a shortened life expectancy at 86? She's already lived her 70. She's already lived longer than most people do. What is considered shortened life expectancy? Now, her cardiologist was doing exactly what he was mandated to do. Here are all the treatment options. She went through and said, no, you are not putting a TAVR valve in my heart, because if it doesn't work, you have to crack my chest, and you're not cracking my chest. No. She wrote that down. She also said, I'm happy with you giving me medicine as long as it doesn't make me feel too lousy. Okay. Mm-hmm. I was her medical power of attorney, which is what you're talking about. And I went to teach a course in hypnosis in Florida. And she had the nerve to go into cardiac arrest the week that I was gone. And so my poor sister was left making all these decisions that I had gone over in great detail with my mother multiple times because she lived with me. Of course, we'd had these conversations. But she didn't want CPR. Her sweetheart was giving her CPR on the floor. They called the rescue squad. They came in and they said, there's a DNR on the refrigerator. We can't do anything. We have to let her go. Because that's what she wanted. That's what she wanted. And so we all dealt with the reality of that decision. But because she had advanced directives out the wazoo, it made a huge difference in how we felt as a family after the fact, to be able to say we respected the wishes that she had. There were a couple of points had I been there where we would have done it a little differently. But in general, it went the way she wanted. And frankly, if I could script to death, I'd take hers. She died at home, surrounded by people she loved. It was the weekend after Thanksgiving. She had seen her entire family. She'd had people come over and play music for her. She'd gone to the movies, and she died at home. Doesn't sound too bad. Doesn't sound too bad.
Yeah.
This is what an advance directive can give you. If you don't have one. Yeah.
Advanced directives, in my experience, when they first came out 30, 50 years ago,
Yeah.
has been a negative experience for me.
Mm.
We had them, medical community dishonored.
I'm so sorry.
A doctor had a piece of paper for my mother, and I asked him why he put her on a breathing machine. He said, because my mother, just a few weeks ago, I put her on a breathing machine. I thought it'd be helpful for your mother. Boy. And I said, I want you to take her off.
Yeah.
He says, I'm not.
Our healthcare system is marginally
I mean,
less.
it's been an educational process for the medical community.
Yes, it
to go
has.
through
Absolutely.
this, and it's taken a half a century.
Yes, it
Yeah.
has. Every bit of that. Every bit of that. You're absolutely right.
And I can cite you 2 more examples. And every time I go in to the hospital, they want to know if I have a medical directive. I say I do. Sometimes they want me to show it,
Mhm.
and it'll be in my chart, and
Mhm.
I'll be willing to bet you when an event occurs for me and they want it, they'll ask my wife, do I have a medical directive? They won't go look at my chart. They won't know where it is.
We've gotten,
Even today, I'm talking about today.
I know. We have gotten marginally better than what you experience, your
I mean,
description
you
is.
all are preaching for us to get the paperwork right, and they don't know how to handle the paperwork.
Without your doing the paperwork, there's no option.
That's correct.
Okay, with you doing the paperwork, as in my mother's case, which was 6 years ago, there was an option. But you're right, it's not perfect. And this is why you want to make
And
sure that
sometimes you gotta go get 2 copies of paper.
every family member that you have, you want to tell them what you want. Don't make it a mystery. And if they disagree with you, tell them why you want it anyway. These are hard conversations to have. They're hard conversations to have with your healthcare team, because we are trained and designed, and well, you've done the actual training. I have not.
And you all, I agree with what you said in your preface there. You all are a working machine to save lives, and you don't know when to pull back.
We're not allowed to pull back unless someone says so. And that's part of the challenge here. And this is where, a colleague of mine, a physician I worked with for a number of years, an anesthesiologist, said the most expensive days of your entire medical life are the last 10. Do you want to say something about that?
Well, then go ahead and I'll ask another question.
Oh, okay. That, for most of us, they will do everything they possibly can to keep us alive, even if we are frail and ancient, because they have to. They don't have a choice. But again, this at least gives you a shot at having a chance. I can't guarantee that every healthcare system that you will be in will honor that. And on a long day, particularly after what some of our healthcare teams have been through in the last 2 years, if you were in any of those emergency rooms during that window of time when things were nuts, and I know you were, it was really hard. And there were a lot of mistakes made, not out of anything other than sheer exhaustion, because no one had a break and we didn't know how to do this. And so we were making it up as we went along. And so, the paternalistic attitude of your mother's physician, those doctors are still out there. I am doing all that I can to train the next generation to get them to be better. I think I've made some progress.
Yeah. And I will assure you guys that I just graduated medical school 4 years ago, right? So I received training on this in medicine. In medical school, they're already teaching the younger physicians, this is important. This is our patient's autonomy, And this is drilled into us in medical school now, and it is becoming a much bigger part of the narrative in our training years. And when we go to residency, in my intern year, I was in internal medicine at VCU, and this was a huge part of the discussion on the ICU services, where you're dealing with a lot of these situations with the medical directives and advanced directives. And we are taught now to make sure that we know what the patient's wishes are from the family. What does their medical directive say? What does their advanced directive say? And so I hope that does give you some hope, that I know that those physicians are out there, and I apologize that was an experience. And I'm sure that it has been an experience for some of you, or you know of those experiences. But I will say that there is hope. From the education standpoint on the national scale, I do think that this is becoming a very important issue that we are getting more versed in. So
We'll keep our fingers crossed.
So, what would you suggest in a case like this to follow up to what you spoke? If someone has an advanced directive, I've always told them, you know, put it on a refrigerator, put it on the back of your bedroom door. Carry it with you if you can. No one's really going to look in your pocketbook, but if you can carry it around, or if you've got it on your phone, in your photos or something in a file, have it. But I've also said, I think you might be able to proactively take it to Bon Secours, take it to HCA, have them put it in the database. If you've already been there, can they put that in a database? And this is why. Because just like your scenario, you're out of town. Let's just say you had a sibling, and what happened, they took mom to the hospital. Do you have an advanced directive? No, but we want to do it right now. Mom is not coherent, or for whatever. This sister
Changes.
So how do we, I have run into 5 opportunities like that in helping families this year. And I've told them this is only the best way I know to eliminate that problem. Any suggestions?
This is where I think the hard conversations become so essential, and they are hard. I mean, I am so grateful to both of my parents for being willing to have those conversations with myself and all of my siblings. So this was not a single conversation. It was an evolving conversation, and it was very clear, because honestly, what you want in an advanced directive is going to change based on where you are in your life and your health circumstances. And it's okay that it changes. But I think saying it should change, absolutely, it should change. So if you, again, I look at my mother at 86, making a decision not to have open heart surgery, which, you know, my husband kept saying, I don't think that's the right decision. I'm like, it's not your decision to make. It's mother's. And he was like, okay. And he believed that. He watched his father go through Parkinson's. He did not have very good advanced directives. And when his brother called at 2 o'clock in the morning saying, they're saying dad needs, you know, major abdominal surgery, but he has Parkinson's and he's almost 90, or he might have already turned 90 at that point, he never got out of ICU. Now that's a death I would not wish on anyone. He was miserable those last couple of months of his life. So, you know, these are the things we're trying to avoid. You know, we don't have crystal balls and magic solutions, but I think the answer to one sister doing one thing and one sister doing another, it comes back to communicating with the entire family, but also knowing, you know, this is hard stuff for people to accept and understand and integrate. And so often the conversation needs to happen multiple times.
Well, there's one thing, you to create the document, the person that has the medical power of attorney has to implement. And then you feel like you're killing the person, okay? But you're doing it for their wishes. That's the way I always do it.
It's their wish, and that sometimes it's hard as a support person, family member, to agree, but it's really not our choice it's whoever's advanced directive it is. It is hard to support sometimes.
Another example I had was an uncle, a nurse in the nursing home that he was at, called me and said they wanted to put a feeding tube in. And I said, is this going to improve the quality of life for him? He was unconscious, okay? Or are you just going to maintain him? You're going to extend his life. You're not going to
Improve his life.
improve his life.
Yeah.
And the nurse said, no, we're just going to extend his life. I said, no.
You know what you can.
And I
also-
based that on the advanced directive
Yes.
that he gave me.
So also, what you should know is in the advanced directive, you can be very specific about what you do not want. I mean, very specific, like no feeding tube,
No
ventilator,
intubation, yeah.
you know, anything like, you can be very specific. I do not want CPR. I do not want a feeding tube. I do not want a ventilator. So what happens is it takes
Or
that,
heroic
right, it takes that stress off of you to execute that advanced directive if you know specifically what they want and what they don't want.
Yeah.
You go about getting the medical people to read it. My dad had a very specific directive posted on the bottom of his bed, on the wall behind his bed.
And they still did it.
Waking him in the middle of the night. And when I raised a little Cain about it, they told me what you said, which is valid, that we're in the business of saving lives. And in this case, we didn't have time. If we were going to save him, we didn't have time to read the paperwork. That infuriated me, but
And it should have, because, I mean, this is what you're talking about, Dr. Pinto, that we are training our up and coming physicians to be more thoughtful about those decisions. It is true when you bring someone into the emergency room. The mistake I made with my mother being out of town was I told my sister to call the rescue squad, which I should not have done, because frankly, it triggered the police having to come because there was a death in the house, even though it was expected. And, you know, my neighbors showed up and there's all this stuff going on in the neighborhood. And I don't know about your neighbors. I have wonderful neighbors who show up anytime I need them. But sometimes we have nosy neighbors who show up when we don't want them. So, I mean, it can be a very complicated set of circumstances.
And the decisions that were made at that time are questioned by the neighbors.
They are always questions, always, even though they all knew what they were. And I'd already had those conversations with everyone around.
Yeah.
So, you know, even in the best of circumstances, things can go wrong. All we're trying to say is that there are mechanisms that are now available that work a little better than they used to, although not perfectly, to allow you to have some voice when otherwise you would not have had one. And that happens, you know, hopefully none of you will ever be in that situation. I want you all to die at home in your own bed, surrounded by the people you love the most. That's what I want for all of you. That's what I want for me. But it doesn't always happen that way. And so these are, yeah, these are the things that we need to do to try to help in that process. So we're just here to try to provide that information.
Take the other foot.
Yeah.
In the hospital, I was a couple of years ago. They say you have an advanced directive. And I do, and I said, what the thought going through my mind, it says, okay, I quit breathing, everybody wipes their hand and walks out of the room and leaves me dead.
Again, this is,
Is there, you know, can you sort of overreact too much of honoring do
This-
not resuscitate or something?
this is why it's really helpful to be really clear. Yeah. Really clear, because obviously you were not as clear as you thought you were.
Well, I'm just asking the doctor, I said, you guys just go wipe your hands and walk out the room and
No, but there's a key word that I think can be helpful, which is called palliative care, which is keep me comfortable.
Yes.
And so those are things, that was what my mother said, keep me comfortable. And those are words that you can say to your healthcare team in advance and also to your children. You know, my mother said, if I get cancer, don't treat it.
Who can help you write one? I mean, you're raising words.
There's a website that is, did you put the website on here?
I didn't put the actual website on it, but if you literally just type in Advanced Directives Virginia into the Google search bar, it pops up with all of these free forms, and it gives you a ton of information about kind of the verbiage, and they have these little gray boxes on the side that help you kind of what exactly goes in that box, you know? And so looking into that, printing out this form and filling it out, the way to actually make it legal is to have a physician, clinical psychologist, PA, nurse practitioner, professional counselor, or social worker sign it with you. And all of those people should be well versed in advanced directives, and you can kind of talk with them and see like, what exactly should I put in this? What words do I need to be thinking of? Point, really, there's a whole box of what do I not want, and really being really specific about what you don't want and what you do want. And maybe it's just to be comfortable. Like, that's great. Put it in there. Like, just think about what you want your end of life to look like and write it down. And that's really what it comes down to. And if you can be more specific, the better. The big things that I think of are feeding tubes. Do you want a PEG tube or a tube in your belly? Do you want a tube through your nose? Those are types of things that we are like kind of questioning if the patient would want. So that's a big thing. Do you want some artificial nutrition? That's a big one. Artificial hydration. Are you okay with getting IV fluids? A lot of times this can make you more comfortable, but it can prolong life at the end. IV hydration is a big one. And then the basics like CPR, intubation, mechanical ventilation. Those are kind of big ones. And then if you want surgery or not, that's another big one. So kind of just if I'm thinking about an advanced directive, those would be big things that I feel like as a physician, when we're in that ICU situation, we're like, okay, what would the patient want in this big circumstance? Those are all pivotal points where we're calling the family and we're talking with them, seeing what exactly their wishes would have been. So I hope that's helpful.
See, what happens is we eat, drink, and sleep what you just said. But the normal people, a lot of them don't even know what a PEG tube is.
Right.
And so what happens is that's why, to what you spoke, it's a smart thing to take that form and sit down with your doctor to make sure that what you have is what you really want.
What's the difference in advanced directive and a DNR?
Great question. So advanced directive is a very broad form. So it really tells us pretty much all of these things, right? Who's your healthcare power of attorney, who or what your preferences are with all of the things that we talked about, and how you want to be treated. The DNR or code status is kind of a separate thing. You can put some of that in your advanced directive, but I believe legally it has to be separate, the DNR. So when we talk about code status, when you come into the hospital, I know VCU, at least as a system, you will get asked what is your code status. And there are several different options. One is full code. That allows your medical team to do everything in their power, everything that they're doing to sustain life. And so that can be CPR, that can be medications, that could be shocking, that can be, everything that we can throw at you.
Everything you've seen on Chicago Med.
Exactly.
That's that.
Very terrible CPR, but yes.
Yeah, terrible CPR, but that's beside the point.
But beside the point. So that's the full code. But then you can have do not intubate or do it DNI or DNR. So those are kind of depending on what health system you're at. Those can be kind of combined or separated. So that's a really important distinction to talk about, because if you want to be, have CPR done, if your heart were to stop, but you do not want to be intubated, you do not want to be attached to mechanical ventilation, then you would be a DNI, right? But if you wanted, do not resuscitate, so that is no resuscitation at all. That's no, the mechanical ventilation, all of that, CPR. If you want basically for things to happen naturally, that is a do not resuscitate. DNR is probably, if you want to have a natural death, that is the best thing that you can do. That is more well-versed, I think, than an advanced directive for medicine, that we recognize a DNR means that we do not resuscitate, that we aren't cracking ribs unnecessarily if that's not something that you want. You know, it can, I've seen CPR really take a toll on people, and that's something that you might not, you know, be thinking about in the moment, but thinking about the quality of life after an arrest is really what I challenge you to think about, and talk with your healthcare providers about, like, what does
And
that
your
actually,
family.
what does
And
that
your
actually
family.
look like for you after?
I mean,
And-
I've had to do CPR in my front yard on my mother's sweetie who keeled over. Now, in looking at it in retrospect, I think he was probably gone before he hit the ground, which I think was probably a good thing. But in making those decisions in the moment as a healthcare provider, and I don't have near the training that Dr. Pinto does, but I've been trained multiple times in basic CPR and in the Heimlich, and I've actually used the Heimlich successfully in the past. So it's a really great skill to have, but it also means that you are at very high risk of cracking somebody's ribs. And if any of you have had cracked ribs, it's very painful. Depending on where it is and how many, it can be exquisitely painful. So, you know, these are the kinds of decision choices that, you know, we all make. And, you know, in the moment, most of us are going to make the save lives decisions, because that's kind of how we're hardwired to do. We have about 2 or 3 more minutes left.
Time goes by so fast.
Yes.
Yes.
I want to mention hospice, because if you have
Yes.
someone who is ill at home, and to avoid the police coming, hospice bypasses the necessity to call the police. One other thing is that long-term illnesses, specifically cancer, there's an organization in Richmond called Cancer Link, Cancer LINC, which provides legal and counseling services to families going through the cancer experience if their income is below a certain level. And they provide legal documents and assist with getting rid of medical expenses that the person can't afford.
That's good to
Great
know.
sharing. That's correct.
That's great to know.
Can you address just for a minute the difference between palliative care and hospice?
Yes.
I'm sure there is a difference.
There
Yes,
is.
yes, there is. There is some overlap. So palliative care, though, is really about comfort, is how I like to see it. So palliative care really helps with managing of kind of those chronic illnesses and with pain management, with kind of that air hunger that we can see. Really just about making things more comfortable for you. That is palliative care. Palliative care physicians are also expertly trained in what kind of the next steps are, including hospice. And hospice is a, basically, if you have a terminal illness and you have less than 6 months to live.
They've changed the timelines a
have they?
little bit. Yeah, they've
Yeah, they
widened
might
them actually a fair amount.
Good.
Yes,
Good.
they needed to be.
So those timelines, which I'm not sure off of the top of my head, because this isn't my specialty, but basically, if you fit within that timeline and you're considered at the end of life, then you can go into a hospice program that is really dedicated on giving you that comfort, like palliative care, and making your last days as comfortable as possible. But really, I guess like palliative can be at any time within
So you don't like have a.
You don't have to have a terminal illness
You do
per
not have
se.
to
Oh, that's-
Yeah, I have a patient right now, actually one we're going to be talking to in not too long,
Mhm.
who is struggling with how much additional care she really wants because she's bouncing back and forth in and out of the emergency room. Which for a lot of folks with chronic illnesses, you know, your doc sees you in the office and goes, I can't handle this. I need you to go to the ER. How many times do you go in a week? And this poor lady has been at least twice a week for the last 3 months and, or, you know, give or take. But how do you then begin to change the conversation about what kind of care you really want? And hospice comes with that assumption that, you know, you're at death's door. That's how most of us think about it. Again, they've widened the lens on hospice. So I think it's now actually 2 years. But, you know, I think in this situation with my patient who does not have a, you know, determined, you know, window, you know, average length of life expectancy, but is clearly saying, I'm not sure how much more extensive treatment I want to do for the problems that I have because I just keep ending up, you know, rotating back and forth. And so you go, well, maybe we need to talk about palliative care. So that's the difference. I don't know if that helps.
So would you kind of do palliative care first and then?
Generally.
Generally. And then palliative care, again, you can start palliative care with like at the beginning of a cancer diagnosis or something like that. It really is the beginning of a chronic illness that could turn into more of an end of life diagnosis. Palliative care is great at symptom management. That is kind of their forte. And so getting them involved early, I always recommend that for my patients because it's really just about having a physician with a different lens to look at your care. And they're looking more at the symptoms, more at your quality of life and that kind of thing.
So there are doctors, there are physicians, and that's their,
Yes.
that's their line of work.
Yes.
Just palliative care.
Yes.
That's a specialty in the same way that physical medicine is a specialty.
Palliative medicine is actually a fellowship. And so specialties from kind of all across the board can apply for palliative medicine. So you can find really a wide range, family medicine trained, internal medicine trained, human art trained, all sorts of different kind of,
Oncology, a lot of
Yeah.
different areas.
yeah, that have palliative kind of training.
One more question.
A technique that I've learned from my wife, psychiatric nurse, who's down your alley, so to speak. You don't ask the person, how are they? She says, how are your spirits today? Okay, and we'll end up getting a different and probably a more truthful answer. Okay, that's something you all should try to remember.
I like that one.
I like that. Right, that's good.
I like that one a lot. I rarely say, how are you doing? Usually I say, it's really good to see you. That's where I start. But I have a new one. Yeah. Thank you.
You touched around that. You said, how are you? Almost said that a couple of times in the condition, but you didn't. I was expecting you to go the other way. How are your spirits?
I think maybe I passed. I didn't completely screw it up.
You taught us something today.
Thank you so much for coming here to be with us today.
Oh,
So much.
thank you. Thank you. I feel like I was ignoring my Zoom folks.
Yeah, I didn't know we had somebody on Zoom.
Yeah, there's 3 or 4 people on Zoom.
Yeah, I think there was 5 total.
Mhm.
Are there?
I'm gonna leave these for you guys. I mean, it's just a copy of our
Sandra
PowerPoints,
Ryan,
just so that
Eric
that
Weems,
information's
Rosie.
there.
An iPhone.
And guys,
Hi,
hold
Rosie.
on. we're not finished. And I'm sorry, you probably did not hear all of the questions that were asked from the audience. So my apology. I'll improve on that in the next meeting, okay? So just hold tight. Ladies, thank you so very
You're so
much. That
welcome.
was
That
a
was-
wonderful sharing. We appreciate your time and the best to you for the rest of the day, the rest of the year. Enjoy your holidays.
Thank you so much. Same to all of you.
Thank you.
Thank you, guys.
Okay,
Perfect.
Bye,
If you
y'all.
forgot something, we know your number.
you know my number.
Bye. I miss you. Okay, to sort of put the icing on the cake, something to remember is this. If somebody does go on hospice or does go on palliative care, you can go off of it.
Right.
So just letting you know that if for some odd reason, and then some people get to the point where they disqualify for hospice or palliative care. So it can happen. You can go to and fro. Okay, to sort of just switch gears a little bit, let's just talk about next month. Next month, right here in this room, we're going to have our Christmas luncheon. It's going to be catered by Mission Barbecue. And correct?
Well, I
Correct.
wanted to talk about that.
Please.
I came up with it, but I want to explore.
Okay, because I think we already have,
Has he already placed the order?
I think he's already placed the order.
So I communicated with
Bill?
Bill, yeah. I don't think he's placed the order yet.
Oh, okay, well then,
but I was
okay,
gonna Talk about it
afterwards, okay, we can do that too.
get some ideas.
Hey,
But-
we're open.
I don't think the Mission Barbecue is set in stone.
Okay, gotcha. I wasn't aware of that.
have a catered meal. We will have a
Perfect.
catered meal.
We'll have a catered meal. So
We can-
come ready for a surprise. Have a